Thank you, Ellie. Good morning and welcome, everyone. We hope you have enjoyed our first day. The sessions were very impactful, and it's been a marvelous opportunity for us to move forward. All sessions have been recorded and have now been uploaded and available using the agenda feature. So if you missed a session yesterday that you want to catch up on, just go to the agenda and click on that link. We'd like to thank our sponsors. I want to put in another plug for visiting the booths. Every one of those sponsors has provided some helpful information about their role in the health data universe that you'll probably find interesting. So it's worth your time to spend a few minutes in each sponsor's booth. There's also an option to request a follow-up contact. By the way, we've had about 80 people participate in the token hunt game so far, and it's very easy to do, and I hope everybody will participate. The winners of the prize drawing from day one are Buki Olagan from AIR, a NATO member, and Sydney Grossbeck from Utah. They won $25 gift cards. The day two drawing will be for $50 gift cards, and the grand prize drawing on day three will include a $250 gift card. So make sure that you get at least some chances to win one of those prizes. We also want to recognize our strategic partners. Thank you all for your year-round participation. If anybody out there is interested in learning more about how to be a strategic partner, please contact me. I would like to draw your attention to the on-demand content section of the conference platform. Over the summer, we hosted a series of webinars dealing with health equity and disparities. Those sessions are all available at no cost to conference attendees. Again, another reminder to save the date, August 14 to 16, 2023, for our in-person event in Boston. Please get this on your calendar so it coordinates with your vacation time so you don't miss this opportunity. We are sad to have learned that over the summer, a good friend and longtime NATO contributor, John Bach, has passed away. We will miss John and his advocacy for standards in the application of health data. At this time, I would like to present the NATO Innovation and Data Dissemination Awards. Since 2009, NATO has honored an organization each year with the Distinguished Innovation and Data Dissemination Award. The NATO Board of Directors established this award to recognize the importance of effectively communicating health data to the public. This year, we have two recognitions. Full citations for each recipient can be read on the NATO website, nato.org/awards. First, in 2002, the RAND Corporation, with the support of the Robert Wood Johnson Foundation and other funders, including Arnold Ventures and the Employers Forum of Indiana, continue to elevate the national discussion about provider price variation and its implications for healthcare access, affordability, and system sustainability. RAND's Round 4 report on prices paid to hospitals by private health plans used medical claims data from self-insured employers and APCD data from 11 states to develop service-level price comparisons across payers, providers, and states to illustrate the tremendous variation in how much Americans really are paying for healthcare. RAND's work reveals the power of claims data to sharpen our understanding of our complex healthcare system and to catalyze movement toward policy and system reform. At this time, we're going to hear an acceptance speech, if you will, from Chris Whaley. Charles, can you make that happen?
On behalf of my RAND colleagues and team members, I'm happy to accept the National Association of Health Data Organizations Innovation and Data Dissemination Award. Health benefits are one of the largest expenses for employers, but most employers and purchasers have very little insight into the prices negotiated on their behalf. With this report from the Robert Wood Johnson Foundation, over the last several years, we have published several studies that collect data from employers, health plans, and state all-payer claims databases to illustrate variation in hospital prices. We consistently find large variation in prices for hospital care paid for by employers, patients, and private insurers. We've also worked with several organizations, including the Employers Forum of Indiana and the National Academy for State Health Policy, to allow for this information to be widely accessible to purchasers and policymakers. The really great part of this project has been to see how this information can actually inform decisions. We have seen purchasers change benefits in networks, have greater insight into prices negotiated on their behalf, and ensure that these prices actually align with the value they receive and the health benefits that they receive. We've also seen this data be used to inform policy decisions on healthcare competition, including both at the state and federal level. This type of data is really critical for employers and policymakers who want to make sure we have high quality but affordable healthcare. Thank you.
Congratulations, Chris. Can you show everybody the award? The virtual handoff. Here you go.
Yeah. And this is great to receive. This is just a fantastic organization. I think has really highlighted the importance of healthcare data.
Great. Thank you, Chris. Our second recipient is the Minnesota Department of Health. The Minnesota Department of Health has recently updated its suite of 6 public use files prepared from the Minnesota All-Payer Claims Database, or the MNAPCD, to include new data elements in a broader reporting period that spans 2012 through 2019. To make this content even more accessible to the public, MDH has developed the MNAPCD PUF dashboards. Through these interactive and user-friendly dashboards, MDH is working to facilitate broad consumption of healthcare reporting for both researchers and the public audience. Charles, can you bring Carl's message to us?
Thank you, and hello. My name is Carl Fernstrom, and I manage the Healthcare Data Service Center and the Health Economics program at the Minnesota Department of Health. My team functions as the operational side of the Minnesota All-Payer Claims Database, Minnesota Hospital Discharge Data, and the state's Medicare Fee-for-Service data. The work we've received the NATO Innovation and Data Dissemination Award for focused on the Minnesota APCD public use files and supporting dashboards. First, I'd like to thank everyone who contributed to the project, which includes my colleagues in the Minnesota Department of Health Health Economics program, Minnesota IT Services, and the MDH Tableau governance team. We also worked with 2 data vendors. Mathematica helped us to conceptualize and implement the prescription drug, provider specialty, and member public use files, add additional years of data, and write documentation. OnPoint Health Data helped us to redesign and refresh the healthcare services, diagnoses, and utilization public use files. OnPoint also helped to design and develop the dashboards for all 6 public use files, including supporting documentation. This project took about 18 months from start to finish, and the primary goals were to help MDH reach a broader audience by providing an interactive format, creating engaging visualizations designed to help draw users in, and expand interest in the Minnesota APCD. Since their release, we've received a lot of positive feedback from a broad set of stakeholders and seen traffic to our website increase. The dashboard development process included key decision points on which years of data to include, how to visually display known limitations of the data, which key metrics to focus on, and what the most effective levels of aggregation are. Each dashboard includes a landing page to help users navigate between public use files, a homepage with engaging visualizations and key metrics, a detail page to accommodate drilling into the data, and a glossary of terms and definitions used in the dashboards. At the outset, we said we wanted to reach a broader audience, decrease barriers to using our data, and I feel we've achieved that. The project team has successfully created consistency across the dashboards and within MDH and developed a brand standard that can be followed in other data release projects. In the future, we are excited to be focusing on additional years of data, fixing minor bugs, and figuring out how to automate the work to the extent possible. Once again, thank you for this incredible honor. In closing, I'd like to thank my fellow NATO members for this award, and I'm looking forward to an exciting annual conference this year. Thank you again, and goodbye.
Well, congratulations to Carl Fernstrom and the entire Minnesota team for representing us so well. At this time, we're going to pivot now, and I'd like to introduce today's opening plenary. The opening plenary today will be a panel discussion, Look Under the Sticker Price, Leveraging Hospital Cost Data to Negotiate Better Rates. This session is sponsored by the Peterson Center on Healthcare, a longtime NATO supporter and sponsor. We want to thank Lance Teagarden and his fantastic team at Peterson for their support again this year. This session was organized by Evelyn Lee. Sule Gerovich from Mathematica will be the moderator. I will now turn the time over to Sule to introduce the panelists. Let's bring Sule on stage. Sule, it's yours.
All right. Good morning and good afternoon, everyone. Can you hear me okay?
Yes. Sounds
All
great.
right. Thank you, Norm. Thank you, Evelyn, for organizing such a panel. And Chris, congratulations. So we are not letting Chris go. So he's going to talk a little bit more about the RAND study and 4.0 in a minute. But we are also joined by a few very distinctive panelists. So first, Marilyn from NASHP. Marilyn Bartlett is an accountant, and she shook the ground in Montana by negotiating reference-based pricing for the state of Montana employee benefit plan. And since then, she's been working in this field and serving as a senior policy fellow at the National Academy of State Health Policy and leading the NASHP's hospital cost report tool. We are also joined by Grace Cordovano, and she is a board certified patient advocate specializing in oncology. And she defines herself as an advocate and defrictionizer. So I'm looking forward to hear about her perspectives on what she sees in the measuring price and healthcare market. And finally, we do have someone from Vermont who defines herself as a data geek, Sara Lindberg, who leads the health finance and data analytics in Vermont Green Mountain Care Board. As I was thinking about all these people joining to the panel, I wanted to find a joke, a data geek, a patient advocate, a health economist, and an accountant joined together to think about the price. So we'll fill out the joke at the end of the panel discussions. So with that, before I turn to Marilyn to talk about her work in this area, I'm also reminded by a paper that was written almost 10 years ago, comparing our system and how much we pay on healthcare compared to other developed countries. As most of you know, we spend more than twice as much as the next country in the developed countries. And the title of that paper was "Is the Price Stupid?" written by Uwe Reinhardt, Anderson, and others. And it's been 10 years, and reflecting on the policy and what we accomplished. We have a lot of data and information out there, but looking back for the 10 years, I don't see a lot of progress in reining in the prices. So I'm curious to hear about the panelists' views on what is going on and how we can change the tide and look at the price a little bit more and control it. So with that, I'm going to turn to Marilyn to talk about her work, and then we'll go with Chris and Sara and then end with Grace. Marilyn? All right, Marilyn, you might be on mute. I can see you talking, but not here.
Is this better?
Yes.
Thank you, Sule. I'm really glad to be part of this panel. I am the accountant of the group, and I'd like to talk a little bit about the NASHP Hospital Cost Tool. Next slide. So what is it? It is an online tool that state officials or healthcare purchasers can use to better understand and address hospital costs and prices. Now, we were interested in looking at the actual costs of hospitals, and the only public data available in that realm, the detail we wanted were the Medicare cost reports. So our tool looks at hospital-specific 10 years of data for 4,600 acute care and critical access hospitals. We're able to get to the hospital data level set by using the HCRIS database, which houses all the data since 2011 from the Medicare cost reports. We developed the tool alongside Rice University, Baker Institute of Public Policy, with the support of Arnold Ventures. And we've been very fortunate to be able to work with Mathematica, who has helped us pull this data together and make it usable. And here is a link to the actual tool. Next slide. So what does the tool tell you? This tool got its beginning here in Montana when I was negotiating with the hospitals. I wanted to pay a multiple of Medicare. No longer did I want to pay an arbitrary discount off of an unknown charge master rate. So I needed information on the hospitals. So I used the Medicare cost reports and the MACPAC reports. So this is one thing that we're looking at. How are hospitals faring? This top left side will show you what the median net profit margin is for national, which is the purple line. And then we looked at the Texas hospitals. This is some work as we're working with Texas on quite a few efforts. 368 hospitals, this shows you 2019, is both acute care and critical access hospitals. But then we decided, let's dig a little bit deeper. Let's look at by bed size. And that's the bar chart that you see below. And you can see the large profit margin on the hospitals that are 250 plus bed size. And you can drill in further on this data. Next slide. So we also, this is something that was valuable for me when I was negotiating, and Stace had been finding this valuable. Let's talk a little bit about payer mix. Chris Whaley has produced some good information to show that cost shifting argument does not have basis. And we're finding that in our data too. So the donut chart shows you the makeup of Memorial Hermann Texas Medical Center Hospital. And it shows you the orange is commercial, the yellow is the Medicaid. But then to the right, we show you the profit margin per that segment of business. And you can start to see, is there cost shifting? Are there losses on Medicare, Medicaid government programs? And it's a good discussion, whether you're negotiating with a hospital or if you're a policymaker. The chart I like are on the right, and this was what I used when I was negotiating. The top chart shows you the drop in the cost to charge ratio, the common measurement for hospitals, their cost divided by their charges. And you'll often hear hospitals say, or even the insurance carriers say, well, they're really dropping their cost to charge ratio. But is that a good thing? Is it because costs went down, or is it because charges went up? So the chart below shows for this particular hospital what has been the trend in charges, what has been the trend in the hospital costs. So you'll see this great disparity, and we find this on most hospitals, which I always argue then, why do you want to reimburse a hospital on a discount off that yellow line? I would much rather go to that blue line plus. Next slide. So we did one more thing with our tool, which is something I had done in Montana too. We looked at a break even. What would a commercial payer have to pay a hospital in order to allow that hospital to break even? So what we calculate is the break-even point would cover the commercial patient hospital costs if there were any losses from other payers, charity care, uninsured, bad debt, all the uncompensated. Then we will cover all the Medicare disallowed costs, research, you name it. And we also bring in the other income, other expense from the hospital. So we look at the full picture. Now, the chart right now is comparing to RAND 3.0, and we have really benefited from our work with RAND, Chris Whaley particularly. Thank you, Chris, that we could bring an apples to apples comparison of what the RAND price shows with the break even. This is for inpatient, outpatient hospital services only, so it excludes the professional component. And we express it as a multiple of Medicare. So it does take into account case mix that has been accounted for. And then it's comparable to be able to look between hospitals and look at RAND. Next slide. So looking at the break-even analysis, this is a trend 2011 through 2019. Again, I'm comparing it to the median for Texas hospitals with the median for national for all hospitals. The median for Texas is a break-even of 135%. So paying 135% of Medicare to this hospital will allow them to break even. The national median is 127%. Next slide. So just a big overview. we're using the hospital cost tool as a resource. We're finding employer coalitions, such as the ones Chris named, Indiana, Colorado, Maine. A lot of them are using the data to work with their employers' self-funded plans and either direct contracting or negotiating. Our big focus at NASHP is working with states. We're working with states on health policy, working with specific state agencies who are a regulator as well as a purchaser on better understanding hospital costs and hospital prices from this data. We have been working with researchers. We provide, Mathematica has developed the site to allow a downloadable data set that researchers can use, along with clear definitions. And then we're also finding use within the education realm. Now, our next steps, we plan on releasing version 2.0 following Rand's trend here. And version 2.0 will be ready in mid to late November. And we'll be including 2020 and 2021. We'll also be including the RAND 4.0 studies. We have also added a new segment onto this, which will talk about labor metrics. What has happened with direct patient care over those 11, 12 years? What has happened to the rates, the FTEs, et cetera? And so we're going to have an enhanced data set. So something to look forward to. Thank you.
Thank you, Marilyn. So we will move to Chris on the RAND 2.0. But I do want to also encourage people to type their questions as the speakers are presenting. So at the end of the introductions, we'll have the conversation, and I'll do my best to include your questions during that conversation. With that, I will turn to Chris.
Great. Well, really great to present some of our work on hospital price transparency and how we've collected this data. And as mentioned earlier, this study was funded by the Robert Wood Johnson Foundation and several participating employers. Next slide, please. And so just kind of the motivation of why we did this study. The employer-sponsored market in the United States is very large. So many people, and I'm sure many people on the call as well, receive health insurance benefits from their employer. So collectively, employers provide health insurance for about 160 million people. That's about half the country, and collectively spend about $1.2 trillion on healthcare, rather, with the largest chunk of the pie, just under $500 billion, going towards hospital care. And so this is a huge and tremendously important market that we really need to have lots of data and have informed policy decisions about. Next slide, please. But this is also a market that has faced many challenges over the last several years. And so if we look at kind of where this huge market has been financed, it's really come in recent years out of worker paychecks and deductibles. And so if we just look at the last decade, there's been a over 160% increase in deductible payments. Family premiums increased by over $54,000. It now costs, I think, over $22,000 to provide health insurance for a family. I know at RAND, we're actually close to $30,000, and so that's just money that comes out of worker paychecks. Inflation has increased by 25%, and of course, in the last year, much higher than that. And worker earnings have increased less than inflation. And so I think there's a growing concern shared by many, myself included, that the way that we're financing this huge market is essentially by taking pay raises out of worker paychecks and paying workers in healthcare dollars. And so that is a policy trade-off that we need to have data and insights to make sure whether that is the correct decision. Next slide, please. And so we also wanted to work with employers because employers actually have a legal and fiduciary responsibility to make sure that they are providing health insurance benefits wisely for the workforce. And so if you look at the Department of Labor website, there's actually some pretty clear guidance that employers as fiduciaries for the workforce have a responsibility to use health plan dollars in the sole benefit of the workforce and their dependents. And so if we're to think about kind of this pretty strong definition of what it means to be a responsible purchaser, it's hard to think that you could actually do that without knowing information about prices. And so what we really wanted to do in this study was give employers data and information on prices that are being negotiated on their behalf, and then allow employers to actually go out and say whether those prices align with the value that they're getting. Next slide, please. And so how we've done the study is we've collected data from 3 main sources. Probably the largest source is self-funded employers. So we've been able to get claims data from individual employers. We've also been able to collect data from 11 state all-payer claims databases. There are many more than 11 APCDs. For some states, there are various restrictions around using this type of data, using APCD data to disclose provider-level prices. And so that's maybe a potential barrier to using APCDs to their full extent. And we've also gotten some data from health plans. And then with these prices, we compare prices in 2 different ways. So one is relative to the Medicare benchmark, and that's the one that probably gets the most attention, is maybe the easiest to interpret, and the one that tools such as the NASHP tool have used to display prices. And then we also have a case mix adjusted price, which is kind of an average walk out the door price. And then with this data, we've actually created a public report. And so you can go to the RAND website and download prices for about 4,000 hospitals. And this report actually names individual facilities and systems and has lots of slicing and dicing of different prices. And this tool is both on the RAND website, but a kind of easier way to use this tool is actually through the NASHP tool to look at break-even prices, and then also the SAGE transparency tool, which is a pretty user-friendly way to look at prices. And then for some employers, we actually have a way for them to actually see prices for their own populations. Next slide, please. And what we've found throughout the study is that prices vary pretty widely. And so prices in some states like Hawaii and Arkansas are relative to Medicare around 150%. And in other states like West Virginia and South Carolina, prices are above 325% Medicare. And so just across the country, comparing average prices, there's almost a 2x range in prices for hospital services. So again, keep in mind, this is a huge industry, and an industry that touches everyone in the country. One thing that we've highlighted in the bottom slide is just the states that have a all-payer claims database. In general, we find that those states are towards the lower end of prices. And so it's hard to tell whether that's because the state's using their APCD to design a kind of more price-friendly environment, or those types of states are just ones where an APCD has been easier to form. Next slide, please. And so as we've been doing the study, it's been really great to just kind of see how purchasers and policymakers have used this data. And the way I kind of think of it is there's really a continuum. So some groups are just kind of finally excited to have information about prices. Some groups have actually gone out and used this data to benchmark their prices. And then finally, some groups, and especially employers, have thought about using this data to actually go out and change their hospital networks and kind of think about the prices that don't align with the value that they're getting as employers and purchasers. Next slide. And so just to wrap up, rising healthcare costs place a tremendous amount of pressure on worker wages and also employers. And I think this is especially true during the COVID-19 pandemic. The glass half full view of all this price variation, if you will, is that this large variation in prices in some sense represents a saving opportunity for employers and purchasers. And so if we can either think about ways of reducing prices on the higher end or getting patients to go to lower price, high quality providers, then that's a potential way to improve healthcare affordability. And then finally, I think data is critical for this market. And so it's really important for employers, purchasers, and policymakers to have this type of data. And then more importantly, to not just kind of have this data and sit on it, but actually to use it to inform their policy decisions. So thank you, and happy to turn it over.
Great, thank you, Chris. And Vermont is one of those states who has the APCD and on the lower end of that graph. So I'm sure Sara would have a perspective on your question. And Sara did a little more detailed analysis on hospital costs for her state. So let's hear from her a little bit.
Thank you so much. It's really an honor to be among this group. So I'm just going to talk about an analysis we did here in the small state of Vermont. If you want to advance the slide. Yeah, so I work for a regulatory agency here in Vermont, known as the Green Mountain Care Board. And part of our duties include approving the budgets for our 14 hospitals each year. And one thing that we grapple with, like a lot of folks, is how to account for price, and in our case, really incorporate cost into that analysis. So we didn't see a lot of available material that could kind of look at both those things in tandem. And one reason that it's high on our minds here in Vermont is we're a very rural state with a lot of critical access hospitals. And so trying to disentangle the relatively high fixed costs we might have to live with is critical to maintaining access in our state. So if you'd please advance the slide. What I think is kind of neat about this approach, if I do say so myself, is that we were able to recost claims from the all-payer claims database at the claim line level. So we use the room and board charges for the type of bed it is for the facility. And we also look at the cost to charge ratios for the ancillary services. And so that way, for that episode of care, we have kind of the Medicare cost reports definition of the cost of that episode for the patient. A lot of analyses will look at the cost to charge ratio at the facility level. And that can be tricky if you have great differences in the types of services that are being provided within a hospital. And we wanted a little bit more granularity in comparing cost as specified in the cost report and also the cost coverage. So if you want to go to the next slide, please. I hope you brought some spectacles. Sorry for the small dots, but this is some of the results we had for inpatient care. So on the, oh gosh, I think it'd be the left side of your screen, you can see what those costs are, and it's segmented by the type of hospital. So the leftmost are academic medical centers, one of which is based in Vermont and one is right across the border in New Hampshire. Then we had our critical access hospitals and the other prospective payment system hospitals. And you can see that, 2020 and beyond is still an evolving mystery, but you can see that the costs did really rise in 20 and 21, particularly among the academic medical centers. And then you can see that cost coverage. So you can see that, no surprise, but sometimes staggering to actually see those commercial cost coverage rates are quite a bit higher. So we see a lot more variation in cost coverage between payers than we do for costs. And if you go to the next slide, you can see that in the outpatient hospital or facility services, that costs are even less variable, which makes sense. But that cost coverage, still is intense to see out there how much higher those cost coverage numbers are for the commercial population as compared to the governmental payers. So it's not news, but seeing it with your own data and the space between these lines, I think gave us all a moment to remember what a big deal this is. And the other interesting thing is that cost not only varies between facilities, but as you see on the next slide, that cost coverage also varies depending on the type of service. So here you can see inpatient, outpatient, and professional services. And you can see that, the governmental payers are on par with the commercial insurers for things like chiropractic services. But things like imaging is where you really see the differential. And here, it's important to keep in mind that there's a lot of noise to untangle. So we're defining cost the way that Medicare would. To do this for a facility, you would want to get a sense of how the revenue codes are working within their billing system. And if I were a betting man, which I'm not, I'm guessing that they wouldn't work the same for even all commercial payers. So that would be quite a thing to untangle, but probably a worthy cause. And if you want to go to the next slide. I think that as no one here is surprised to learn that this is very complex information. And we see that, the variation exists across time, across different types of hospitals, and even within the hospital based on payer and the type of service. And so as regulators, what we need to try to grapple with is how we can consider this in our regulation of hospitals and, embed that if not just for monitoring, if there's any more direct regulatory approaches we can take to kind of narrowing that variation. All right, thank you.
All right, and I take the blame for those small dots on the slides. I had to consolidate some of it, so that's all on me, not on Sara. So with that, thank you so much. I think what we are hearing is Marilyn and Chris, you really focused on the prices where you are targeting employers and those who negotiate with hospitals to get a better deal. And what we see in Sara's is a little bit more looking from both access perspective, given the rural nature of their state, that they need to ensure that the cost from the hospital side, what is the cost to the hospital, is financed so the access is maintained. So I do have questions, but before I get to it, and there are some coming from the text, Grace, what are you hearing? Like, so what is your perspective given what you do on your day-to-day life?
So just for everyone who may not know me, my day-to-day is working with patients and their families as they navigate catastrophic diagnoses, a majority of which are cancer. But as you know, when you have a cancer diagnosis, doesn't mean that your congestive heart failure or your diabetes or other circumstances go away. I'm absolutely floored. I think there was so many powerful pieces of information here, but if I had to pick the ones that really resonated. Chris presented a slide where the deductible and the family premiums are skyrocketing. And I see this financial impact and the financial toxicity that people are dealing with. So, healthcare has an issue with labeling patients for being non-compliant, non-adherent, canceling their appointments, waiting until it's too late and going to the emergency room. But if you look at that slide, the reality is most people cannot afford to access the care that they need at the time that they need it. So the financial toxicity component is loud and clear. And I find it intriguing that the variation in hospital prices that Chris was commenting on presents a cost savings opportunity. I do help families when they're navigating their bills to never pay the first bill, especially when they've had extensive care, a long hospitalization. Many patients and families, for example, hospitalization post-COVID. Bills were coming rubber banded in stacks daily. Okay. It's looking at the itemized bill. It's calling for assistance and support. It's ensuring that things are correct because, again, to the point, there is variation and there is an opportunity to negotiate and to work together to some kind of a agreement where most people would say, oh my goodness, I just need to pay this as quickly as possible. Or do I need to take a loan? Do I need to do something drastic? File for bankruptcy? And I think we need to convey, using that information, the opportunity for savings, not just for employers, but how do we educate patients, consumers, and families how to hack the billing process and this financial toxicity component. Sara, I really loved the data that you presented, and what really stuck out on me on the variation across facilities and services, there were some dots that were really far over to the right. And if I understood them correctly, it was imaging, cardiovascular, OBGYN. That essentially impacts everyone. So I find it very intriguing that those are the high cost features. I don't think there's anyone on this panel who isn't touched by imaging, cardiovascular, OBGYN. So how do we navigate that as consumers? I find that concerning that the dots are so far over. And how do we really educate, from my perspective, patients and their families to better prepare when things are not in an emergency state, but also how to brace themselves and have the tools, information they need to advocate for themselves when catastrophe does hit. And I think the tools and the technologies and the insights that you have pulled together can really help people boots on the ground.
Great comments. Thank you, Grace. Any reactions from the panelists how we could take this data and educate families and patients? Anyone who would like to comment?
I have less a comment on that, but just more a general comment. I mean, I think at least from my perspective, we look at a lot of these, cost and affordability issues through kind of the lens of spreadsheets and data. And so, as part of doing that, I think miss in many cases or gloss over the patient side. So I think the work that Grace and others do on actually making sure that this resonates with patients is incredibly important.
And Marilyn, I know you got a lot of requests to use your data, and then you provide technical assistance with that. So can you talk a little bit like who reached out to you and what were the main questions and how you're helping them? Marilyn, I think you are still on mute, honey. Yeah. Let's see. All right, hold that thought, and hopefully someone in the background can help you to unmute. While we are trying to figure out that one, I will read a few questions that we received, and perhaps somebody else could answer that as well. So Dawn Garland asked, different hospitals may have different cost accounting methodologies. How does the NASHP tool account for that when comparing hospitals? So let's see. I guess, Sara, you did look at the Medicare cost report. Anything that you want to mention in terms of the variation?
Yeah, so clearly, when you're looking at this, the payment flows much differently for Medicare. So we saw generally less variation among the critical access hospitals than we saw for some of the other facilities. And so it's so hard to translate this into tidbits that are kind of helpful from a consumer's standpoint. And I think that's even an employer purchasing group. And one thing we struggle with is, and it kind of reminds me of when you're looking for a car, there's like, there's the price when you first buy it, but then there's like, what's the true cost to own? And so if you're thinking about population health, how can we help think about, it might actually, the price might be higher for you as a consumer in this moment, but you're likely to have a higher value service and less at risk of a complication or need for a corrective surgery. So I think, and then we have like all the bizarre funds flow. So from a consumer's perspective, what that cost might be to you, the hospital may not even know because of contracting issues. It comes up a lot for anesthesiology and labs and whatnot. So it is, no one would sit down and develop this system. But I would say as far as like the facility variation, I think everybody can pretty much tie it to the cost report. They have to. But I think that at the end of the day, the devil's in the details and there's a lot of discretion. And so it's the best place we know to try to look at this on an apples to apples basis. Sorry to digress a bit there.
No, thank you. That was really helpful. Marilyn, can we hear you now?
Can you hear me?
Yes, perfect. All right, so the question to you was what the reactions you received to the tool and how you think, what kind of assistance you provided so far. And the other one that Sara answered, but I'd love to hear your thoughts about is the variation, and maybe industry came to you and said, well, you can't really use the cost report that we submitted to the federal government.
Good questions. And Sara, thank you. I totally agree with her responses. The Medicare cost report really follows the Medicare cost instructions. And I agree with Sara. There can be some variation, but it is pretty standardized accounting. So I saw the question about hospitals use different accounting methods. That's correct. But the Medicare cost report instructions really takes that variation out to the best it can. I think it's good. I work a lot with audited financial statements, and you see much more variation in those than that. Yeah, we've received some interesting responses. We're working a lot with states on state policy. Specifically, we were able to work on mergers and acquisitions, what happened pre and post, what happened pre and post on COPAs, working with some data for the FTC. We've been able to actually help stop a merger, which was interesting by analyzing that, as well as hospital closures. What was the true financial position? With some states that are working on cost growth benchmarking, price benchmarking, public option and pricing. We've been able to work with them extensively on what that would look like and what is an appropriate rate. We have also been able to work quite a bit with the state as a purchaser. We've worked with state employee health plans using their data through RAND and using the benchmarking tools to be able to help them negotiate some do direct contracts. Commercial, that's an interesting one. We've been working with a lot of employer forums. We've been working with some employers directly, helping them with the data to be able to do direct contracting. Probably the most public one is 32BJ Union in New York that began using our data probably 2 years ago when we were still building the tool, and we're able to use it to look at Presbyterian Hospital when they remove them from their network. So we've been in the background supporting where we can from all those angles.
Thank you. So switching gears a little bit, Joe Porter's question is around COVID. And I know, Marilyn, you mentioned you are adding the staffing information, reflecting on some of the conversations happening right now after COVID with hospitals' costs going up and mainly contractual labor and additional costs that they are incurring. But Joe Porter is asking about your thoughts around how the analysis of hospital financing should reflect and account for costs of care that were COVID related and paid for in different ways, as well as unique payments made to hospitals through COVID related federal payments. So ARPA and other programs, as you know, provided additional funding during the public health emergency period.
Yes, we're starting to work on that data with Mathematica for 2020 and 2021 with RISE. And the Medicare cost reports require the hospitals to report the revenue they received from those sources you mentioned. So we see a specific field for COVID PHE funding coming in. We're capturing that as a call out data that will be in the downloadable data set. Also, we're seeing the money come in government appropriations that might have come through the state level too. So we are seeing the funding come in. The interesting thing is on the Medicare cost reports, that comes in as other income, not in hospital revenues. So we are making the statistics work with that. So we are factoring that in, and it does come into break even, and that will be with analysis in our next round. And we are looking at what happened with direct patient staffing during that time, considering the trend over that time. Was direct patient staffing for the hospital actually fairly flat and then came up a little bit as far as hourly rates? What happened when contracted rates come in? And Mathematica is going to be helping us analyze that further.
Anyone else is working on COVID-related issues around price or cost?
Yeah, I think one thing to keep in mind with a lot of the COVID care is that, and this is something that we've actually highlighted in our report, is that these were services that were still, especially on the commercially insured side, reimbursed at relatively high rates. And so, certainly the pandemic did place a strain on many hospitals and delivery systems, but a lot of that strain was accordingly compensated.
All right. As we are waiting for additional questions, I have one. Chris, you mentioned when you talked about APCDs and some of the restrictions on publishing prices for providers. What are some other barriers to measure price in healthcare? Like, why don't we have those? These are great work. It took us a while. It took us 18 to a year. Like, what do you see as major barriers to calculate or publish prices?
Yeah, so I think an APCD is just a fantastic resource for a state, and so it's really good to see how states like Vermont and I think Colorado and New Hampshire are also very good examples who have taken the time and energy to invest in creating APCD, but then are actually not just kind of letting it sit there, but actually using the APCD to inform their own state policy decisions. One of the barriers that we've seen with other APCDs and kind of becoming that type of example is a lot of kind of statutory or other kind of restrictions in how the APCD was set up. So in some states, for example, Florida, you can collect an APCD, but outside researchers can't actually post, or I think even the APCD itself can't post prices for specific providers. And so in many cases when we're making these challenging price and affordability and access questions, that's the type of information that we actually need to have out in the policy community. And so that's kind of a barrier to actually, I think, fulfilling the kind of full kind of scope of what an APCD can be used for.
And Sara, it sounds like you cracked the nut a little bit and went under and did service line analyses on the prices. So how are you going to use your data moving forward?
Pardon me. The state of Vermont is charged with a comprehensive look at kind of the sustainability of its delivery system. So we have 625,000 people, which I believe still keeps us ahead of Wyoming, but that's about it. And so, it's hard to balance these access and, expense issues. And so it's hopefully it's something to begin a conversation about what we're willing to pay for in our communities and, the trade-offs we'll have. But we look forward to working further with Mathematica to answer some of these very important questions.
Yeah, Sara and I work very closely, just full disclosure, on these issues. I think, we talked about the policy levers, and all three of you kind of focus on policy, and Grace mentioned how she's working with the families. Just putting that hat back on, because the data, the complexities. Maybe first, Grace, like if you wanted to have one or two data points, what would that be? And then I'll ask the same questions to our experts, and maybe then I can come up with my joke after it, how we all came up with that elusive discussion or the dashboard. So Grace, what would be helpful from your perspective that you'd like to see more of from people like Chris, Marilyn, and Sara?
I'll give you an example. So in oncology, or really in like catastrophic cases where you don't have a lot of time to wait around for an answer, a patient may be prescribed a treatment or a procedure or imaging, and they need this to be approved by their insurance company or pre-certed or authorized. And often the insurance company will deny it, even though it's prescribed by a board certified or dually board certified physician. And there's a lot of back and forth while a patient is deteriorating and getting significantly worse, more anxiety and stress. Sometimes you just want to know, well, what is the out-of-pocket cost? What are we really talking about? Is it a few $100s? Because I can't wait 3 weeks. I'd rather invest and pay out-of-pocket cash. Or is it worth me driving an hour instead of waiting for this back and forth and the headache that my physician's office needs to go through to do a peer-to-peer letter and a peer-to-peer call while they have 96 other patients to worry about? So all of these pieces of information are so important because people have lives that they need to live and important decisions that they need to make. I think we forget it's not just about the cost, it's the decisions that rely on this transparency. Whether you're caring for aging parents, whether you're caring for younger medically complex children, whether you're trying to manage your own diagnosis, all of these decisions can't be taken lightly, especially when you're dealing with chronic illness, something life-altering, life-limiting, and even end-of-life care.
Thank you. Anyone else would like to chime in to that question? All right, while we are thinking about other questions, I do have a few comments. Sylvia Hobbs mentioned outstanding advice, Grace, on the first bill payment. And though it may seem counterintuitive, Paul Levy, the former CEO of Beth Israel, would agree and did suggest at a forum at Harvard that the patients delay paying the first bill. So that seems like a good advice from multiple people. And Beth Egan has a question for Marilyn. So thank you for your great work. How can you say there is no cost shifting when commercial payers are making up for the lower payments from Medicaid and Medicare, as well as charging in excess of that? So that's a good question. Thank you, Beth.
And I'm going to have Chris help me with his data on that. But basically what we're finding is that, and I found this in Montana, when a hospital says we're losing 40% on Medicaid, you've got to look at the payer mix, because that particular hospital, 9% of their payer mix was Medicaid. So if you're losing 40% on 9% of your business, that's a really different story. We're also finding, and we found in Texas, large profits being made on Medicaid. They have DSRIP payments and other federal payments coming in, upper limit payments that come in. There are a lot of funding sources. So what the tool does is show you what is the profit on Medicare, Medicaid, SCHIP, and other low income programs. How much is really being lost, and what is that payer mix? Because you have to analyze that in great detail. Now, the fact that the commercial payments are high, and that the argument is cost shifting, I really think the data, you've got to dig into the data to see if that's a valid argument. Chris Whaley, I'm going to ask you about your plot graph.
Yeah, so I think we all know that commercial payers pay more than Medicare and Medicaid. The cost shifting argument is that commercial payers pay more than Medicare and Medicaid because of underpayments from Medicare and Medicaid. And that I think one way to kind of think about how that makes sense is that in recent, this past year, Medicare announced its largest increase in hospital payments in the last several decades. And so if cost shifting is true, then what that means is that commercial payments should go down this next year. I don't think anyone thinks that that's actually going to happen. And we actually looked at this kind of empirically in our study. And so what we did is we said, let's compare the rate of patients that a hospital has that are covered by Medicare, Medicaid, or uninsured, and compare that to a hospital's price. And so again, if cost shifting is true, the hospitals that have the most Medicare, Medicaid, and uninsured patients should be the ones with the highest price, and those that have relatively few underpaying patients should actually have lower prices. And you can see this in our study that we actually found no correlation between the two. And the real kind of reason that hospital prices vary and that some hospitals are higher priced than others is just kind of the market or negotiation or kind of access environments that allow those hospitals to negotiate better prices with insurers.
All right, let me make sure I'm not missing any questions from the audience. Chris, yeah, I think that's a great point, like to debunk some of that arguments why the commercial prices are going up. And you mentioned analysis that you looked at the variation. Besides the market power, do you have any other plans to look at that variation and do additional analysis using your data?
Yeah, so we certainly have some ongoing work that's looked at that. And basically what we find is that every market is unique, and that uniqueness leads to large variation in prices. So in some markets, you've got a dominant hospital system that's able to negotiate higher prices. In other markets, maybe the hospital system has the same dominance, but the insurance carrier is also big, and so they're able to kind of put a little bit of downward pressure on prices. In some markets, we see that some hospitals are just in remote areas, and so they're able to kind of negotiate higher prices out of that. And I do see that the comment from the chat. We haven't actually looked at what's the correlation between hospital prices and things like CEO or kind of executive pay. One thing that we are looking at now, actually using some data from NASHP and the hospital cost report data, is investment income. So some hospitals have lots of investment and make lots of money in the stock market or other investments, and so if they kind of story that high prices are need to offset business losses or kind of other stresses in the business, then what we should see is that when a hospital does particularly well in the stock market one year and has high investment returns, and that should put a little bit downward pressure on prices, but actually we don't find that in the data.
I actually have a question. And this may be for Chris, Marilyn, or for Sara. I'm just curious, is there a way to keep track of how many claims are denied by insurance companies and how that correlates with their costs?
We haven't looked at that in our study. I think, a challenge of looking at claims data, whether it's through employer data or APCD, is that we're really looking at the claims that have actually been paid, and so any claim denial is kind of maybe the tip of the iceberg, where we actually don't have great insight using existing data. And so I think to answer the earlier question of kind of what should other data assets and resources be, my response is that we need to. We've got lots of insight into kind of where we know to look, but there are many parts of the healthcare system and where patients interact with the healthcare system, and then also how providers, say, deal with insurers, et cetera, where we just don't have the same type of knowledge.
Yep, and I think on the hospital side, at least, when you look at the cost that Marilyn showed, even if they didn't get paid, it will reflect on the cost of providing services. So both Sara and Marilyn's analyses are picking up that portion of it. I think I will reflect comments that on the denied question that we hear occasionally, that some plans boost profits by aggressively denying claims, but data and analysis is lacking. So I think it's a great place to kind of think about future work. There is a question, and I think, Grace, this might be relevant for your work. What about those with no insurance? Is there any negotiation with hospitals for them to reduce their full-priced bills? What is your experience there?
I typically connect patients with charity care programs, and even that is a very complex process. I am brought to tears pretty frequently with what people need to go through to really access care that they desperately need, and it's still denied as medically unnecessary, not meeting the criteria. And a lot of situations where there's women trying to access care, they're told to go relax. They're not believed that their pain is as reported. So it's a very complex problem, and I think that connecting patients to organizations that, for example, I'll throw out the Patient Advocate Foundation, a great foundation and organization that has case management services that can help patients navigate these situations, as well as providing directions on various types of financial assistance when maybe charity care isn't a possibility, or they're just significantly underinsured. So thank you for bringing that up. But I do think that having, again, this type of information can help you connect to care that you may be able to afford or may be willing to invest in a payment plan or something like that, versus not being able to access it at all.
All right, thank you for that. So that was a great question, Jana Brooking, sorry. So given the complexity of the charges, right? So the people who don't have insurance are going to get the bill based on charges, and then we have the negotiated prices, and then what you eventually pay. As you are thinking through analyses on the hospital prices, what do you see happening? Because now with the transparency laws that federal government enacted, more data is going to be out there, and it's already out there, right? All hospitals are publishing their prices. We get similar data from the insurance companies. So where do you think this conversation is going to be going if you had the crystal ball, or what you are planning to do with that type of data?
I think one thing is that I've been working quite a bit with those hospital pricing, the hospital price reporting through the federal legislation, and the TIC, the transparency and coverage from the plans. And the data is, it's tough. It's not easy data to work with. But when you do get it, you can often see the cash price. And the cash price for the hospital typically runs below. And you can, it was interesting to hear. I didn't realize that it's not an easy process to work with a hospital on the charity care. That was really good for me to learn today. But I think that as we push further on price transparency, and if enforcement, kind of came along, I think that would be so helpful for Grace's group, for all of us, if we could get that price transparency. And that you would hope that that transparency would then lead into a market approach where prices go down versus up. And so I'm hopeful about that.
I just want to add one thing. Many patients rely on Kickstarter and GoFundMe campaigns to be able to cover their expenses. So something as simple as knowing what the target and what the goal, and then having it in writing so it's a no surprise bill, and understanding that it's not going to be additional surprise out of network costs, can make all the difference and remove so much stress that a person and their family may be going through as they try to navigate what could be a very catastrophic moment in their life.
I guess my comment would be that it's been 20 years since Uwe Reinhardt wrote "It's the Price is Stupid," and since then the prices have gotten stupider. And so I think now is maybe a time for us collectively to decide what are the policy or other kind of technology or other solutions that we can get ahead of and implement and get behind now, so that in 20 years whoever's rediscovering prices isn't saying there's a lot of variation in prices, and look at how expensive things are in healthcare.
And I'd just tack on that, in Vermont, that's one of the main reasons we're so interested in changing the way our hospitals are paid, through alternative payment mechanisms and thinking about value-based care, but also is can think about, per capita budgets for hospitals, to really try to incentivize keeping populations healthy instead of doing stuff to people.
All right, that's a great comment, and it requires another 1 hour to think about alternative payment models and how to change the way we pay, which is my passion. Thank you so much for all of you, for all the work that you are doing, and for this 1 hour sharing your work and perspective. So I'm going to turn to Norm to close the session and see what's coming next.